Hi everybody. This is going to be an overview of acid-base balance. I will try to take a little bit of break just because I know that this is a longer presentation. So it will typically go over the normal 30 minutes that I try to keep PowerPoints to, but really it's just there's a lot of information. So let's go ahead and get started. So remember, when you are looking at anything in a patient's body, any concept, in the end we are attempting to get our patients back to some level of homeostasis. So we're going to talk about acid-base and if blood is too alkaline or too acidic. A lot of the normal bodily functions cannot take place. It can change the distribution of electrolytes. It can alter the excitability of certain cell membranes, like muscles and nerve fibers. And decreased pH or acidity can actually denature proteins, which you have to remember hormones are a type of protein. So again, a change in the pH will affect hormones. Hydrogen ions are going to be key when you're dealing with acid-base balance. It comes down to the concentration of your hydrogen ions that determine the acidity or the alkalinity of the blood. So you have an increase of those concentration, you will get a acidic pH. A decrease of those concentration in the blood, you're going to get an alkalotic pH. So again, this next section is going to be a short review and really kind of goes back to chemistry. So if you're talking about acid-base balance in chemistry, a liquid of a pH of 7.0 is considered neutral. And so that is the number and strength of acids and bases are equal. And that's really important because if an acid is stronger, it will have a greater effect. If the pH is below 7.0, the liquid would be considered acidic. And when we're dealing with patients, we're talking about their blood. And that is the number and or strength of acids is higher than that of the bases. So if you see here, more acids, or if there's less base, even though there's relatively the same number of acid, or if the acid is stronger versus the base that's represented. If the pH is greater than 7, the liquid will be considered alkalotic or basic. That is, the number and or strength of the bases is higher than that of the acid. So you see here there's either going to be more base represented, or less acid that's relative to bases, or if a stronger base is present. So if we talk about normal blood pH, is going to be slightly alkalinic. That ranges between 7.35 to 7.45. But the same principles apply regarding acidity and alkalinity to blood as it does with just liquids. So if the pH is less than 7.35, it is considered acidotic. If the pH is greater than 7.45, it is considered alkalotic. And your mid-normal point is going to be 7.4. The major players when we're looking at the pH of blood is going to be carbonic acid, which is considered the body's main acid. And that's really because it gives up its hydrogen ions. Bicarbonate, on the other hand, is considered the body's main base. That's because it actually accepts hydrogen ions. So when the hydrogen ions are equal to the number of bicarbonate, typically a neutral pH exists. When there are more hydrogen ions than bicarbonate, an acidic pH exists. And when hydrogen ions are less than the number of bicarbonate ions, an alkalinic pH exists. So let's kind of get back to the saga. So what do you think happens when there is an increase of CO2? I hope that you said that it increases the acidity. So somebody who has impaired breathing will typically have respiratory acidosis because they're holding on too much of CO2, which is also an acid. So increased CO2 results in increased carbonic acid, resulting in increased hydrogen ions. So on the flip side, what do you think happens when there is a decreased concentration of CO2? Decreased CO2 results in a relatively increased concentration of bicarbonate. So this type of individual would be in respiratory alkalosis. Acid-base imbalances occur when there's a concentration of hydrogen ions that is either too high or too low, and the body's regulatory systems just cannot seem to keep up. So at this point, it's really about the inability to compensate that makes it difficult. And also remember, too, that while carbonic acid is the main acid in acid-base balance, many others are produced by the body that can influence this balance. When carbohydrate metabolism takes place in the body, CO2 is a waste product of glucose breakdown. Fat and protein metabolism creates sulfuric acid, fatty acids, and ketones. An anaerobic and incomplete metabolism of glucose and fats can produce lactic acid and fatty acids. As well, when there's destruction of cells, some actually contain acid that are released into the extracellular fluid when they are destroyed or damaged. So what happens to all that acid? So just remember, these waste products are transported from the cells into the extracellular fluid in a variety of different ways. After that, the acid are hopefully transported to either the lungs or kidneys. And it's in these areas where they should be neutralized or excreted from the body. So you have to think of things that a person does that can increase the acid load in the body. These could be things like exercising, when the heart stops and somebody has cardiac arrest, cell destruction starts to happen, which will release acid. And unfortunately, CPR also increases acidity because when you are doing compressions on a person's body, you are potentially compressing and causing further cell destruction. So the major concept that you want to look at is the body regulates the pH through homeostatic processes that can involve either chemical, respiratory, or the renal system. And this kind of goes back to how does the body compensate for the changes in pH in order to try to get it back to that normal range of 7.35 to 7.45. So regulating means that the body balances the number of acids and bases to try to get back to that. So an imbalance happens from an illness or injury. The regulatory system may not be able to keep up with a pathological condition that occurs. So some of the regulators of the acid-base balance, you have chemical buffers. Their job is to quickly return the pH to neutral. The respiratory system is kind of the second line of defense. It will monitor and control carbon dioxide levels. And the renal system will try to control bicarbonate and hydrogen ion levels. And interestingly enough, part of the buffer system, blood is also one but it is one of the systems that is actually rarely used in the body to correct pH. So the first line, we're going to talk about chemical buffers. And remember, a buffer is a weak acid or base that neutralizes a stronger acid or base. They are the primary regulators in the body. They can respond quite quickly. They're present in both a person's blood and tissue. There are several chemical buffers. There's bicarbonate, that is the primary chemical buffer, proteins, the largest source, and carbonic acid. These buffers either take up or release hydrogen ions, neutralizing the harmful effects. Once a buffer is used, though, however, is no longer available. So kidneys control the production of bicarbonate, and lungs control the production of carbonic acid. So why do you think bicarb and carbonic acid are considered buffers? So basically, acid is a buffer to an alkaline and vice versa. As I mentioned before, hemoglobin is an intracellular protein buffer. It can actually work in two ways. It can directly combine with hydrogen ions. It also buffers some of the acids produced by metabolism. Our second line of defense that we're going to talk about is the respiratory system. It's twice as effective as a chemical buffer, but it's short-acting. It controls the amount of hydrogen ions by managing the amount of CO2 in the blood, and breathing is the way the body excretes the extra CO2. And you have to remember that the concentration of CO2 directly correlates to the concentration of hydrogen ions. And sometimes the respiratory system can take care of bigger changes in the pH. If you breathe slow and shallow, it will help retain CO2. But if you breathe deep and rapidly, you'll blow off that CO2. So when there is an increase in acids, it will actually stimulate the body to increase the respiration rate and depth. Again, it blows off CO2, resulting in a decrease of hydrogen ions, and it will help raise the pH. So respiration rates go up, right here, and CO2 and hydrogen ions will decrease. And that will actually help to raise the pH of the blood. This is also known as hyperventilation. So it is the way that the body will respond to an acidotic state. So in this way, we're going to talk about how the respiratory system acts as a buffer. When there's a decrease in acids, it will stimulate a decreased rate and depth of respirations. This will actually cause the lungs to hold on to CO2, resulting in an increase of hydrogen ions and a lowering of the pH. This action is known as hypoventilation. Again, it's the body's way of correcting an alkalotic state. The renal system is going to be our third line of defense. It is slow acting. It does not kick in for several hours, and it peaks in about 72 hours. But it is the most powerful. And the reason why it is the most powerful, it does work through the process of diffusion and osmosis, but it's the strongest because it does actually produce bicarb. The renal system The way that it helps is when there is a high pH in the body, the kidneys will actually stop producing bicarb. And when there is a low pH in the body, when it is more acidic, it will excrete more of the hydrogen ions to try to get it out of the body, and it will help to reabsorb more of the bicarb to help elevate a person's pH or the blood's pH. And when there is a high pH, when a person's blood is alkalotic, it will excrete more of the bicarb and reabsorb more of the hydrogen ions, again to try to bring back balance. So the four different imbalances that we talk about with patients are going to be respiratory acidosis, respiratory alkalosis, metabolic acidosis, or metabolic alkalosis. And if you need kind of a brain break, now would be a good time. So the first one we're going to talk about is respiratory acidosis. So this results from a problem in the respiratory system. It can be a result of hypoventilation, which can cause a decrease in level of consciousness. It can depress the respiratory drive. Also can be caused by paralysis of the diaphragm, airway obstruction of either the major or minor airways, and it can also be caused by decreased alveolar capillary exchange, and that can be due to a vascular or lung disease. So to put it in perspective of some actual disease processes, it could be caused by obstructive lung disease, chronic bronchitis, emphysema, sometimes with asthma in later stages, may be a result of sedation from anesthesia or head trauma, neuromuscular diseases like polio, myasthenia gravis, Guillain-Barré syndrome, and also too, it can be a result of increased work of breathing that can result in respiratory failure, which increases the CO2 levels. So what causes hypoventilation due to respiratory depression? Could be inadequate chest expansion. It could be airway blockages, again, or decrease alveolar capillary exchange. Knowing what the cause is going to help you and other healthcare providers better treat that patient, because in the end, you need to kind of get to the etiology to correct the pH balance. Now, talking about respiratory alkalosis, this is going to be the opposite of respiratory acidosis. This is going to involve a problem with the rate and depth of respirations, may be caused to hyperventilation or decreased availability of oxygen, like hypoxemia, which leads to a decreased CO2 levels, resulting in decreased hydrogen ions, resulting in base excess. Sometimes problems that can cause this, like actual causes, hypoxemia again, congestive heart failure, anxiety, pulmonary fibrosis, and even a pulmonary embolus. Pregnancy at times can cause respiratory alkalosis, and relative can be hyperventilation that happens with mechanical ventilation, fever, severe anemia, and even gram-negative septicemia. Moving to our metabolic disorders away from respiratory, this is going to be either overproduction of hydrogen ions, under elimination of the hydrogen ions, underproduction of bicarbonate ions, or over elimination of bicarbonate ions. Some conditions that can put a patient in a metabolic acidosis state could be diabetic ketoacidosis, excessive diarrhea, because again, remember the intestines are basic, renal failure with an increase of lactic acid, poisoning, extended use of TPN, and having excessive ostomy drainage as well. And when there's an actual loss, that is when you'll only use bicarb at that time. Other ways that there can be an overproduction of hydrogen ions is through lipolysis and ketosis. And this is when the body uses too much fat and protein for an energy source. This can happen through diabetic ketoacidosis or starvation. It can happen through anaerobic metabolism, which happens during seizures, fever, and hypoxia, but also having too much acid in a person's diet or what they intake, and that could be through alcohol, methyl alcohol, and aspirin. And also too, that we've spoke a little bit about, is even fad diets like the keto diet. It can also happen as an under-elimination of hydrogen ions. Even if the body makes a normal production of acids, kidney failure can result in that decrease of excretion. Underproduction of bicarbonate ions can also cause metabolic acidosis. Bicarb, again, is produced in the kidneys and pancreas. So if your patient has renal failure, pancreatitis, or liver dysfunction, this patient is going to be at risk for metabolic acidosis. As well, in the over-elimination of bicarb through excessive diarrhea and overuse of bicarb as a buffer. On the flip side, with metabolic alkalosis, this is when there is a base excess, and it's actual, if there's an increase in bases, this could be due to ingestion of oral, which is through excessive use of antacids, milk. It could be parental through the use of TPN, and even through blood transfusions because of the preservatives. It can be a relative problem with acid deficit where there's a decrease in acids, and this may happen with excessive vomiting or NG suction. Because again, remember that the stomach is very acidic. It's an acidic environment, and if you are removing that from that environment, you are making the body more basic. So now that we know a little bit about acidosis and what causes it, we're going to talk about the manifestations of it. Remember that acidosis is a central nervous system depressant. So in terms of how the patient may present, they can come across as disoriented, weak. They may be tachycardic, having dysrhythmias, difficulty breathing, may have some weakness and paralysis. Also, one of your primary electrolytes that may be elevated with metabolic acidosis will be your potassium. Also at the same time, but not as, not that it's not critical, but also during acidosis, you will see a decrease in protein binding, which can increase the number of free calcium that is in the blood. So some patients may have an increase in their calcium levels during metabolic acidosis as well. Treatment, obviously first with respiratory acidosis, you're going to monitor your patient, the respiratory status, their cardiovascular status, their neurostatus, and their Abg interpretation. You want to improve your patient's respiratory status through different techniques of turn, cough, deep breathing, provide oxygen as prescribed, bronchodilators, narcotic reversal if the cause is from overuse of narcotics like opioids. This will be through the use of Narcan or naloxone. Ventilator support for patients that need it, and pulmonary hygiene. Again, it's going to be about assessing and monitoring your patient, but coming to the root cause of what the underlying problem is. One disease process that we will talk more in depth later, diabetic ketoacidosis, is going to be more about reversing the cause of that, which typically with that patient subset is a lack of insulin. On the flip side, when we're talking about metabolic alkalosis, remember that it's going to be a CNS irritant. Patients may present with some irritability, seizure precautions, paresthesis, numbing and tingling, and they may have a positive Trousseau's or Vajtek's sign. And I hope you're stopping and thinking a second, like, well, wait a minute, why are we looking at Trousseau's and Vajtek's sign with metabolic alkalosis when this is more of an issue with calcium? Well, what happens in the body is that when pH increases, alkalosis will actually promote an increase to protein binding, which actually decreases the calcium that is in the serum. So patients with metabolic alkalosis may also have issues with low calcium levels. So that is why there is more effect of the central nervous system, and these individuals, you will want to put them on seizure precautions. Also with cardiac, you will see increased heart rate, and kind of depending, blood pressure will be dependent on the person's cardiac output. Manifestations, respiratory may see some hyperventilations with these individuals, cramping, twitching, hyperreflexia, and skeletal muscle weakness. And as an inverse relationship where metabolic acidosis, you saw an increase in potassium levels, with alkalosis, you will typically see a decrease as well in potassium. Treatment for respiratory alkalosis, monitor and assess, watch the patient's respiratory status, their rate, what their O2 sats are, and again the Abg interpretation. Emotional support, anxiety reduction, rebreathing techniques, and O2 therapy as prescribed. With metabolic alkalosis, watch the patient's respiratory, cardio, and neuromuscular systems, and treat the underlying issue. If it's a result of excessive vomiting, then antiemetics, fluid replacement, electrolyte replacement, and if there's if it's also related to a potassium depletion, whatever is causing the depletion of potassium, DC that and consider replacing the potassium. And in that terms, make sure for testing purposes that you know the max rate in which potassium can be administered, issues you may run into with giving potassium by IV. Do not give potassium by IV push unless you want to kill a patient. And also know the other forms in which potassium can be given to a patient. So in terms of doing Abg analysis, the method that I typically teach students is the Rome method, which basically states respiratory opposite, metabolic equal. Make sure you know your pH range, your CO2 range, and your bicarb range. Respiratory opposite, basically if the pH is high, typically the patient's CO2 level is going to be low, which results in alkalosis. If the pH is low and the CO2 is up, it is acidosis. When you compare the pH to the bicarb, if they are both going the same way or both are elevated, it's alkalosis. And if the pH is low and the bicarb is low as well, going in the same direction, is acidosis. When we talk about compensation, this is again, how is the body compensating for the pH range that is out of balance? Because again, in the end, when you're looking at ABGs, it's going to be all about that blood serum pH. So when you look at your compensation, make sure you do it in a systematic manner each time. The first thing you will do is look at the pH. If it is normal, then basically it's compensated, and you don't really need to look at both the CO2 and the bicarb. If your pH is out of range and your CO2 and bicarb are out of range, then it is partially compensated. If your pH and only one of your other components of CO2 or bicarb are out of range, then it's considered uncompensated or no compensation. Make sure that you do the practice problems, get comfortable with doing Abg analysis. At least in this course, you're getting a very basic understanding. You'll go more in depth into different types of Abg disorders in your critical care class, but at least this will help you get just a general basis. So look at the other PowerPoint that goes over ABGs, and also too, there should be a video about diabetic ketoacidosis that will give you a little bit better understanding about metabolic acidosis and the relationship with potassium. That's it.